Good morning, everybody, or good afternoon and good evening, as someone pointed out. Welcome to the second installment of the EIM Research Learning Collaborative, or the EIM RLC. We now currently have over 250 members spanning every continent in the world, a very exciting initiative. And today we have a very special presentation by two key leaders in our ACSM and EIM Global Network. Today's presentation, PAVS 101, Assessing Patient Physical Activity Levels. What we're going to do today is quickly go over the vision of the EIM RLC, talk about EIM always, make sure we're always grounded in the fundamentals of what our goals are with exercise medicine, and then turn it over to our two presenters today and finishing with a good period of discussion. I have everyone on mute. We have a good number of participants on the call. Would highly encourage everyone to use the chat room, introduce yourself, post comments throughout. I will help moderate and we will do questions at the end. So as a reminder, the EIM Research Learning Collaborative is an initiative to bring together peers to learn, share, and apply best practices from the academic research community combined with the wisdom of frontline service providers. And I think you'll see that today. We want to focus on the dissemination, adoption, and adaptation of best practices for integrating physical activity into diverse health systems. So our final goal with the RLC is to increase the capacity and connectivity of research scientists at all levels, students, early career, exercise professionals, senior professionals, to expand the evidence base for making physical activity assessment and promotion a standard in clinic care, connecting healthcare with evidence-based physical activity resources for people everywhere and of all abilities. If you haven't done so already, you can find our website just by Google searching EIM RLC. It's the first item that will come up. So a little bit about exercise as medicine then. So what are we researching with the RLC? First, our vision with exercise as medicine is to make physical activity assessment and promotion a standard in clinical care, connecting healthcare and patients with evidence-based physical activity resources for people everywhere and of all abilities. We do this through a systems approach by making structural and policy changes to affect standards in healthcare, by integrating assessment and referral pathways into electronic health records, and by showing a commitment to building a bridge of trust, connecting to community patient physical activity resources for our patients. In the healthcare environment, we're hoping to see routine physical activity assessment and screening, brief advice and counseling, and or the provision of a physical activity prescription. Finally, we need to refer patients to physical activity resources. Some of you may be familiar with the SBIRT model. It's a very famous model used in substance use treatment. And in this, our EIM model falls hand in hand with that. So today, really, we're going to be focusing on this first part, the routine physical activity assessment and screening. Our presentation will examine the initial integration of physical activity assessment in the Intermountain Healthcare system, beginning as early as 2010. As well as the subsequent data extraction analysis. We're very fortunate to have two speakers. The first today will be Dr. Liz Joy, a past president of the ACSM and currently a senior medical director of wellness and nutrition at Intermountain Health, as well as an adjunct professor in family and preventive medicine at the University of Utah School of Medicine. She'll be followed by Dr. Trever Ball, the director of clinical research and data quality for population health at Northwell Health in Long Island, New York. He formerly worked with Dr. Joy at Intermountain Healthcare and the Institute for Healthcare Delivery and Research. So with that, I will turn it over. Let's see, stop my sharing and allow Dr. Joy to jump on and take it over. Dr. Joy, the floor is all yours.
Thanks, Mark. Well, and thanks to everyone who has joined the EIM Research Learning Collaborative today. Trevor and I are really looking forward to presenting the information today. I'm I'm just going to quickly make sure with Zoom that I have got the right presentation up here. Let me just take a quick scroll. All right. Excellent. Okay, well, we're going to start out, and I'm just going to, provide an overview of what we did and how we did it when it came to developing and integrating a physical activity vital sign into not only our electronic health record, but really the clinical workflow, and to make it meaningful for providers, members of the clinical care team, and most importantly for the patient. So I'll start with just a little bit of an overview of Intermountain Healthcare. I'm going to talk about what we call the PAVS pitch. Who did I talk to? What did I say? A little bit on the timeline so people have realistic expectations in terms of how long does it take to actually do this. And then I'm going to turn the time over to Trever Ball, who's going to talk a little bit about the validation we did, some work around quality improvement, and now moving into research using the physical activity vital sign to improve healthcare and health outcomes. So Intermountain Healthcare is an integrated healthcare delivery system. We're based in Utah, but our clinic and hospital work extends into Idaho and Nevada. We currently have 24 hospitals, about 2,400 employed physicians and advanced practice professionals, 81 primary care clinics, and as I mentioned, we are an integrated delivery system, including an insurance company called Select Health that covers just under 1 million lives. And more recently, we stood up a population health services organization called Castell, which is not something I'm going to talk about directly as part of the development and integration and implementation of PAVS, but is turning out to be an important part of our work going forward, really looking at the data collected through the physical activity vital sign is not only something that can help at the point of care with individual patient assessment and counseling, but also is going to become an important measure within our work at improving population health. So Intermountain Healthcare, has something referred to as clinical programs and services, and you can see them all listed here. And what is often referred to as the secret sauce, of Intermountain, is that we have developed these multidisciplinary teams within these clinical programs and services that include expertise in clinical care. So they have medical directors, expertise around operations, because you can have great content, but if you cannot operationalize it, it's going nowhere and it's not going to be utilized. And then we have a very robust data structure, which you'll hear more about from Trever, but it's not only, the back end of the data, but it's also the people who are managing the data, who are analyzing the data, and are developing the architecture of that data. And again, this is just a preview of what Trever is going to present, but that part, it turns out, is really, really important. So really what supported a lot of the work that we did around the physical activity vital sign, its foundation is Intermountain's long history in quality improvement and data-driven healthcare. And what you see on the left-hand side of your screen is the front page of the New York Times Magazine a few years ago. And this is a picture of Dr. Brent James, who's really one of the, I'll be so bold as to say, one of the world's leaders in quality improvement. And he spent much of his career at Intermountain Healthcare. And within this article is a quote from President Barack Obama, who went on to say, "We have to ask why places like Intermountain Healthcare in Salt Lake City can offer high quality care at costs well below average. We need to identify the best practices across the country, learn from their success, and replicate that success elsewhere." So we really leveraged, the culture of Intermountain Healthcare around best practices and high value healthcare to develop and implement the physical activity vital sign within our electronic health record. And that kind of moves me to this idea of the pitch. And I love this quote, "Be so good, they can't ignore you." And I really, I took that mantra to heart. as we were doing this work. And again, I'm going to go through the steps about, how and who did we present this information to and in such a way that they couldn't actually ignore us. And I thought I would start with this. And the names and the pictures aren't important. What's important here is that leadership engagement in this was and remains critical. And I reached out and talked to anyone who would listen to me. In the upper left-hand corner with the red box around it is Dr. Mark Briesacker, who currently is our Chief Physician Executive within Intermountain Healthcare, and he actually partnered with me on this project. He thought it was critically important in terms of improving care, particularly in primary care settings. And he and I actually developed and integrated the PAVS into the electronic health record as part of a quality improvement project. Below Dr. Briesacker is Dr. Charles Sorensen, who is CEO, who at the time of this work was the CEO of Intermountain Healthcare, and thankfully is a very active guy himself. And we know from the literature that if your leadership is actively engaged in wellness activities, they're more likely to support that work being integrated into clinical care. And others on this slide are people who were leading our health promotion and wellness, our community health, our clinical programs in primary care. We had a great leadership team, and engaging with them on a regular basis was critically important to this work, and again, remains so to this day. So that's the who. Then we really moved into the why. And, when I'm talking to all of you, when Trever and I are talking, when Mark Stoutenberg is talking, we know we are preaching to the converted. There is nobody on this webinar this morning who doesn't believe that, physical activity is important to health and well-being, and that physical activity assessment and promotion in healthcare is integral to healthcare delivery. But not everybody I was talking to believed that. And so, and I know that this is some older data, but I wanted to share with you what I shared with our leadership and with my physician colleagues once the PAVS was implemented as to why we are doing this. And I shared with them that, our adults age 18 and older, are not meeting recommended physical activity guidelines. And I think people were pretty stunned to see, that only about 15% of females and 21% of males were achieving adequate physical activity. I think they were stunned by how low those numbers were. And again, recognizing this is older data, but this is the data that was presented at the time. And what I shared with them is, certainly, physical activity is part of energy balance. We know that rates of obesity are increasing and that lack of physical activity plays a role in that. And Brent James, whose picture I shared with you previously, he has a saying that was, national data is good, local data is better, personal data is best. And, what I was sharing here, to our leaders is that, yes, Utah has lower obesity rates than other parts of the country, but what you were seeing over time leading up to the integration and implementation of PAVS is that just like other parts of the country, our obesity rates were steadily climbing. And at the time we were doing this work, about a quarter of Utah adults were considered obese. And of course, we leveraged high impact journals. So we shared with our leaders the work that from the Lancet Physical Activity Series and research from Dr. Ayman Lee showing that physical inactivity, contributes to nearly 1 in 10 premature deaths. And that if we could actually change that, if we could decrease inactivity by 25%, as was found in this analysis, we could avert 1.3 million deaths worldwide every year. So again, trying to leverage all different types of information to show our leadership how important it was that we address physical activity, or more importantly, address physical inactivity, as a way to improve health. We also, of course, leveraged, the work of high-profile investigators. And, we're all on this call grateful for the work and the leadership of Dr. Blair and his colleagues when they were part of the Cooper Institute and since then, but showing them, that, conditions like obesity, we know that's bad. Smoking, we know that's really bad. Hypertension, high cholesterol, diabetes. But when you're really looking at all-cause mortality, what contributed to an even greater extent, was low cardiorespiratory fitness. So, this high quality research was very important in terms of the why we had to do this in our healthcare system. I think another myth that we had to overcome was that, talking about physical activity, well, it's just the healthy people. I mean, they're really the only ones who are interested in physical activity. And the rest of the people, well, yeah, it may be important, but I don't know if it's really worth our time. And so, sharing this work, that was published back in the New England Journal back in 2002. So, this data is now 10 years old when we were presenting it, at the time of the PAVS development and integration, was to show that, when you're really looking at the relative risk of death relative to, physical activity levels, it matters across all conditions, whether someone has high blood pressure, COPD, diabetes, smoking, obesity, or hyperlipidemia. So we wanted to share with them that physical activity is important for all people. And it's particularly important for people who have established diseases. Now, if we were actually having this presentation, in person, perhaps at a conference, maybe one of these days we'll get to do that again, I would typically pause at this point and say, and ask all of you, how many of you were weighed at your last in-person physician visit, and ask you to raise your hand. And my guess is that, you probably all were weighed at your last primary care physician visit, maybe not at all specialty care visits. But at the time we were doing this, I think Kaiser Permanente, under the leadership of Dr. Bob Salas, was probably the only large healthcare system, at that point that had integrated, in their case, the exercise vital sign into their electronic health record and into clinical care. And I love this quote. It comes from JAMA back in 2004, from, again, Dr. Blair and Dr. Church. And I think it's worth repeating that, the medical community needs to lead in communicating the importance of physical activity for health and weight maintenance. And just as weight is addressed in some manner at nearly every physician visit, so should attention be given to recommending the accumulation of 30 minutes a day of moderate intensity physical activity at least 5 days of the week. So again, it was really important statements from key leaders, across the United States and the world that helped us in making the case for a physical activity vital sign. And then, of course, the work of Exercise is Medicine, which does in fact call on healthcare providers to assess and review every patient's physical activity program at every visit. So there was a lot going on in this space, and a lot of convincing evidence that physical activity was super important, that people are not being physical activity, that healthcare needs to be involved and engaged in this effort. This is one of my favorite slides, and it's this whole idea that, we need tools. We need tools, and we need prompts that will help us do a better job, in healthcare delivery. And, we have tools for a lot of the downstream consequences of physical inactivity. We have sphygmomanometers to assess blood pressure. We have scales to assess people for overweight and obesity. And we have, angiography, to detect heart disease. But what tools did we have, in order to, integrate, a regular assessment of physical activity into the exam room? And, I'm fond of saying this, that, the exam room is super crowded with all sorts of different agendas. It turns out the physician has an agenda. The medical assistant has an agenda. And believe it or not, as we, I mean, I say that in jest, but the patient has an agenda. And I think one of the most important things the PAVS does is it really serves as a prompt to ensure that physical activity is discussed at each visit in the context of that patient's health. And of course, it helps a lot, with our work that we had our very first physical activity guidelines for Americans published back in 2008, which were, again, guiding us all across the spectrum of healthcare and public health, to address physical activity as a way to improve health for all Americans of all ages. And subsequently, the development of a national physical activity plan to support implementation of the physical activity guidelines. And I'm just going to share, and again, this is from the first iteration of the National Physical Activity Plan and from the healthcare sector. And you will note that strategy 1 from the National Physical Activity Plan was to make physical activity a patient vital sign that all healthcare providers assess and discuss with their patient. So again, we have overwhelming research. We have overwhelming recommendations from leading organizations like Exercises Medicine, Physical Activity Guidelines for Americans, the National Physical Activity Plan, that this is work that we must do in order to improve healthcare delivery and health outcomes. And so we ultimately were successful. We developed the physical activity vital sign. We integrated into the electronic health record we had at the time, which was referred to as HELP 2. And it asks the questions you can see here on the screen. And it had, by the way, it had great product placement. It was right across the vital sign in the upper right-hand corner. It was impossible to not see this. And so if these fields were blank, it was kind of, staring at you in the face, that you hadn't addressed physical activity, you hadn't asked about it or addressed it in the context of the visit. So the first question was, on average, how many days a week do you perform physical activity or exercise? The second question, on average, how many total minutes of physical activity or exercise do you perform on those days? And those are automatically multiplied by the electronic health record to give you minutes per week. And then we asked people to describe the intensity of their physical activity. Light was defined as a casual walk, moderate as a brisk walk, or vigorous was akin to jogging. And then there is another drop down that prompted the physician or the advanced practice provider or a clinical assistant to indicate whether the patient was counseled to start, increase, or maintain their physical activity. Now, I didn't include a slide on this, but I will tell you that this, particularly this last field, really was designed to align with the Medicare Health Outcomes Survey. And the Medicare Health Outcomes Survey is sent to a random sample of Medicare enrollees, and it asks people if they were seen by their primary care physician within the last year, was physical activity discussed during that visit? And if the answer is yes, there's a branched question that says, if the answer is yes, did your provider counsel you to start, increase, or maintain your physical activity? And in order to get credit for physical activity assessment and counseling, albeit this is advice, you have to have a yes answer to both those questions. And physical activity assessment and counseling is considered a HEDIS STARS measure within for CMS. And the STARS measures influence reimbursement to healthcare systems for Medicare. And so that's a really big deal. And you want to be at the 4-star level or higher, for each of the STARS measures, because then it maximizes the reimbursement that systems receive from CMS for healthcare delivery. So, that is why the vital sign at Intermountain Healthcare includes not only days per week, minutes per day, total minutes per week, intensity, which allows us to get to METs, as well as a drop down on physician counseling. Another question I get quite regularly is, why did we include light physical activity and not just moderate to vigorous physical activity? And again, I would argue that everyone on the call knows that the most important change people can make when it comes to physical activity is to go from nothing to something. And of course, we want them to get up to that level of 150 minutes per week of moderate to vigorous physical activity. But we know that people accrue health benefits, significant health benefits, going from nothing to something. And so our clinical leadership felt very strongly that we talk about light physical activity. And of course, since that time, there is an expanding volume of evidence showing that, again, light physical activity results in health benefits. And so I know that, again, what the public health recommendations are, but we do find, and Trevor will share some data showing that even people who are getting insufficient physical activity still have lower rates of healthcare utilization and lower costs compared to those that we define as sedentary. So this, some of this work that I'm showing on the slide came after the integration of PAVS, but we know that simply asking people about their physical activity, having it serve as a prompt, in the exam room, to integrate discussions about physical activity in discussions around well-being and health. I mean, that's really important. And similar to smoking, there's research showing that that brief assessment and advice using that SBIRT model makes a difference. But we have since gone much farther. We've developed a whole care process model on lifestyle and weight management in support of how to use the PAVS, how to use that information, how to use the 5As and other strategies to counsel people about physical activity. We have integrated referral workflows to our medical fitness centers into our electronic health record. And as an integrated delivery system, we have worked with our payer, Select Health, to develop benefits and incentives for patients around regular physical activity. So as Mark was sharing at the very beginning of this webinar, we're really within Exercises Medicine, we want to have physical activity as a vital sign. We want to develop referral pathways to connect people to resources so that they so it really starts to lower some of the barriers to physical activity. So I'm nearly done. I'm going to transition this over to Trevor, but we knew we hit the big time, with the work we were doing around physical activity assessment and promotion, when our CEO, Dr. Charles Sorensen, in his monthly blog post, had a story on making physical activity a vital sign. And so I will tell you that this is a blog that, all probably at the time, 35,000 Intermountain employees saw every time they logged into our system, our intranet. And that was on our intranet for about a month. And we got great comments, great feedback. And what it is showing is that, we were starting to become not just a tool, not just a process, but now this is part of the culture. And, this was, several years ago, and it's just continued to expand from there. And I'm really grateful for all of the team members, including Trevor, who I've been working with since he was a graduate student, for their work. It's really been an incredible team that has made this happen and continues to make this work go forward. And one of our a recent conversation with our insurance company chief financial officer, when he said to me, Liz, I think getting people to move more is the strongest lever to pull when it comes to improving population health. So this is the timeline. You know, it started way back in the early 80s, you know, with the development of our Health and Fitness Institute, you know, the development of our health promotional wellness program in 2007, you know, and now we've gone through, you know, 2 electronic health records. This is fully integrated into our clinical workflow. And so just to sum up my part of our presentation this morning, you know, I think we were successful because, you know, we really had that perfect storm of, you know, a critical mass of leaders who, you know, including myself, who was, had the content expertise, you know, the passion and the energy for this work. I had the right message, you know, to help convince our leaders to move this forward. We had a culture of quality improvement, and we were really starting to recognize, you know, the importance of physical activity in keeping people well, addressing the rising risk population, and the importance of physical activity in chronic disease management. So that alignment with existing initiatives was critically important. So I'm going to stop there. I'm going to turn it over to Trever. I'm going to stop sharing here so he can pull up his slides, and then we'll have some time for Q&A.
Okay, Mark, is that coming up okay?
I believe so, Trevor. PAVS
Okay.
Quality Improvement and Research, correct?
That's correct. Sounds great.
It's all you.
All right, thanks, Liz. Yeah, so let's transition. You know, after we got this thing implemented, led by Liz in this particular health system, you know, our next step was to assess some forms of validity of this actual self-reported measure of physical activity. And we actually did some of that research before implementing it into the electronic health record of the healthcare system. We looked at it. We compared, you know, self-reported responses from patients with their concomitantly measured physical activity from accelerometers. We compared their self-reported physical activity levels from the PAVS to another kind of widely accepted gold standard you know, modified activity questionnaire. And then once it got into the electronic health records, we looked at, in terms of validation, we looked at, you know, Liz mentioned some comparisons to whether some construct forms of validity. You know, are we seeing the relationship between responses to the PAVS as we would think it would be related to disease prevalence or maybe even rates of obesity, you know, knowing that this activity is correlated with those different kinds of things. So I'm going to just kind of flash through several slides about the validation process of this particular physical activity vital sign that we use. And mostly just to kind of illustrate, you know, the different forms of validity that one can do and with this work. Validation, as many know, with different self-report instruments and other measures, you know, patient-reported outcomes, is an ongoing process and an ongoing, you know, thing to refine and improve. Liz and I have learned, and others, you know, it's most important to get something in there and drive the conversation, and you know, and it does actually drive and relate to outcomes, as I'll show at the end here. But I'm going to go through these slides quite quickly, you know, and you know, this will be recorded, so thankfully you can, and the slides provided, so this you can look at these more closely later. You know, so we looked at, you know, the relationship between accelerometry measured physical activity and physical activity measured by the PAVS. So, you know, we might identify that as a criterion form of validity, and it was moderately correlated. Most significantly, however, the rate of patients reporting to the PAVS as having met the minimum aerobic physical activity guidelines was very strongly correlated to that same rate measured by accelerometry. And we thought that was the most important in being a kind of the triage measure in the healthcare setting, right? Whether or not you advise them to increase their activity or maintain, or what be it, you know, kind of use that as a diagnostic measure, if it were, of whether or not they're meeting or not meeting public health physical activity guidelines. And another form, when you're looking at this with, when you're validating these measures, you can look, you want to look at the level of agreement, you know, Bland-Altman plots, as well as some kappa statistics. and other things. There's something called uh, repeated agreement or repeatability. That's talked about by Bland years ago, and so that there's some slides just for reference to that. Meaning, if one patient says, they get this level of activity, and if they were, in all controlled condition, blinded to answering to the PAVS again, if they met that, would they report the same amount of physical activity? So can you measure, apples to apples and actually track progress within patients, as they're changing? There's also something important to do is model some measurement error. In the future, this is some studies people can do in validating these measures, is to look at what physical activity levels are being reported by a physical activity vital sign, and then compare those to what probability sample of that same patient population in the healthcare system is actually being measured objectively by a criterion measure such as accelerometry. Compare the difference between that self-report and the criterion measure, which would be the measurement error, the discrepancy between the two, and then implement that measurement error into the background of the electronic health record to make an adjustment if it were to whatever was self-reported by the patient for the other covariates involved. What gender were they? What was their age, etc. And so we might consider that modeling the measurement error. And that this could be an important thing to do in the future, because if we're looking at physical activity vital signs, the self-reported measure of patient physical activity, which is most feasible, much more than objectively measured, as we know currently. If we're looking at relationships between those things and disease or healthcare costs and other important, very criterion or objectively measured health outcomes that are available in electronic health records, it'll be increasingly important. It could be for that measure of physical activity from the patient to be accurate. And we can do this by modeling the measurement error. There's a couple slides in here that you'll have there with a reference at the bottom on how to do that. Just go forward. And so, we looked at the correlation between moderate to vigorous physical activity being assessed by the PAVS and a modified activity questionnaire. So moderately correlated. We looked at agreement as well. The average days being reported by people to the PAVS as having achieved 30 minutes or more of physical activity. And again, it was moderately correlated. And we looked at difference in people, these same correlations between people who had self-reported having low confidence of reporting their physical activity compared to people having high confidence reporting physical activity. Those that had high confidence naturally had a higher correlation with physical activity and other construct measures of physical activity. So once it was in the electronic health record, we looked at, let's skip right to that. The percent, this is once it was in the physical activity, the electronic health record, what percent of people reporting, these patients reporting physical activity that have, what percent of them were actually meeting the public health physical activity guidelines? So there's a little over 30,000 patients in our first kind of champion clinic at Intermountain Healthcare. And these percent people reporting meeting aerobic physical activity guidelines were about the same by other self-report national kind of representative surveys from the government. So that was good to see. And then we looked at other forms of construct validity. What were the odds of people being placed into a given BMI category when they reported from the PAVS as not meeting physical activity guidelines? Because we would hypothesize, of course, that those reporting not meeting public health physical activity guidelines would be more likely to have higher classification of BMI, and we found this to be true. And disease burden too. What were the odds of high disease burden when not meeting physical activity guidelines assessed by the physical activity vital sign? And we found the same thing, that those who were not meeting physical activity reported to from the PAVS did in fact have higher disease burden as measured by a Charlson Comorbidity Index, for example. So those are some validation examples. Some of the processes that have gone through this even before we began really doing a lot of quality improvement with the physical activity vital sign itself. The next step was, in this implementation of a PAVS, was what I call the data architecture. is actually, Liz mentioned we have really good placement of the PAVS into the front end of the EHR for providers to enter their patient physical activity. And that was great. On the back end of that, for those who have worked with healthcare data, on the back end of that, all that data is going somewhere, of course. And it's critically important to work with a data architect in the healthcare system to understand the where that data is going to go, how it's going to be organized, and for an exercise scientist or like training to work with that data architect to make sure those things are organized in the data tables that are in the back end, that are organized appropriately. The reason being is because if you're going to use it for research down the road, you might get in there and find that there's a lot of kind of misplaced columns of data or misnamed domains of physical activity that are being measured from the PAVS, et cetera. You're going to have to do a lot of cleaning up. In fact, at Intermountain Healthcare, just for kind of, expectation-wise, this took us a few years, actually, after we implemented the physical activity vital sign. It was so new at that time. It took us a few years to actually get into the data, because the PAVS changed in minor ways over the years, and the data architects that were stewards over managing those particular elements of data in the data warehouse, they changed names a little bit, et cetera, nomenclature, those kinds of things. So it took a few years to identify where are these things. And I'll just flash a few slides to give you an idea of really the kind of the depth and the breadth that an electronic data warehouse or an enterprise data warehouse in healthcare is. These data warehouses have data coming from all over. We have finance data, lab data. We have our master reference data to align patients, with billing data and clinical and hospital data, et cetera. And there's a lot of data. Even a couple of years ago, to give you an idea, this was over almost 300 billion rows of data in this one enterprise data warehouse for one healthcare system. And there, a lot of data analysts, a lot of data architects have to be employed to work with this data. So when you look at the PAVS, Liz flashed this visual of, what the PAVS looks like at Intermountain Healthcare. This is what it looks like, or how you can think of it when that data is being entered into the data tables on the back end in the data warehouse. You have, you have your minutes per day being measured, days per week, minutes per week, your intensity in a device, and other things as they come along. And they, this is literally what it would look like as reported from one patient on one encounter. And with that data, then, though, you want to make sure, that this is consistent. You want to make sure, okay, the analysts working with it are working with the data architect. The data architect's working with the exercise scientist and the provider. So you have this little team to understand, okay, we're collecting this data now, but they need to know where in their data warehouse it's located. What is the name of that table? Where is it? And start playing around with it and going and then doing some further validation and some quality improvement with that data now that it's being measured. So that's the next step, is kind of, okay, it's getting entered in there, now let's do some quality improvement with it. And with quality improvement, when you first get in there, this is, these analysts, this work is a lot of work. There's a lot of, this is SQL coding, digging around, where is this data located? And it can take a while to kind of develop those kind of, I would say, those scripts of coding to pull the data out. And once you have that script, then you can kind of pass it along. If you've adopted and passed it off as being good quality of identifying the PAVS domains accurately, et cetera, you can pass that along to other analysts, other researchers. But that's the first step in that quality improvement, is going and querying the data out. And that's a lot of work. And when we do that, then we built at Intermountain dashboards using software that tracked, the percent of encounters in primary healthcare where the PAVS was being used, where patients were either assessed or advised or both for physical activity. And we tracked it over time. And this visual here, it might be small on the screen, but began a little after 2012 and continuing. And you kind of see, you can track your your leadership's efforts to use PAVS, efficiently, et cetera, and adopting it. You can track different initiatives. and so forth, incentives that are used systematically, and you can see if those are making an influence. You can then filter it by specialty. You can look at clinics. You can pass this information along to clinics and let them go with it, and as we know, clinics are, when they see data, they're competitive, both within themselves and between clinics as well. So this was the kind of the visual of what you want to get with the quality improvement effort and track that. You can look at it by provider. The provider, an individual provider may want to know, how are we doing? How am I compared to, Dr. So-and-so, et cetera? They might want to be doing better. And finally, after this has been, quality assessed and so forth, we really are prepared to do research with this. And we can now look at relationships with physical activity that is a record set of data that is just so rich in other health outcomes. And here's a slide. There are some example domains of population health that are kind of the predominant domains that or relationships of variables we might want to look at with physical activity measured by a PAVS. There are health clinical outcomes, a myriad of those, of course. There are financial outcomes, social determinants, and of course our drivers are independent variables of health behaviors, right, from the PAVS. So in conclusion here, let me show just a couple examples of how these data, now that it's all in there, it's clean, we know where they're located, data architect wise, we can start now querying and look at the relationships between things. First thing that we did at Intermountain Health with research is we pooled a bunch of data, 6 years specifically of adult data, persons seen at our clinics, at primary care clinics, who had physical activity measured and recorded through the PAVS reliably, who had visited their PCP, primary care provider, at least a couple times a year, and had the PAVS measured at least a couple times a year. And over 6 years, it was almost 500,000 patients. This was actually over 2.5 million unique measures of patient-reported physical activity. And so you can see how this can just start to take off when you have multiple clinics or hospitals. And when we looked at this, it's, I wouldn't say fairly easy, but for researchers or statistical analysts in a system, they know how to join these physical activity data with other data, such as average annual hospital costs, substratified by physical activity. And you see that those who were inactive did have, on average, much more, even almost twice as much average annual hospital costs. This is a measure that is of interest to a healthcare system, because if patients are costing more in the hospital, and that cost is then being kind of shunted onto themselves at the healthcare system, and they're being reimbursed equally for all persons, they're going to be incentivized. They want to lower their hospital costs. So, promoting physical activity in this way can help with that. And then you can stratify these things, obviously, by disease conditions and look at those similar relationships. What if we substratify again by hospital costs, by chronic disease and physical activity level? Those who were self-reporting, as being sufficiently active for their minutes of moderate to vigorous physical activity were indeed, even within different chronic disease categories, costing less than the inactive patients. So there's a lot of research here that can be done, and this is just kind of an introduction of some training that we look forward to providing in the future. So this is to summarize. Key with this is this partnership. Physical activity champions such as Dr. Joy, analytics, working with the data architect, the exercise scientist. Think population health data architecture. Begin with the end in mind, and that's really important. You really want to begin with that end in mind, and as you go and kind of just getting in there, and it may be an exciting thing, but really be thorough on the front end, and it can save you a lot of time from having to work with that data in the end. And just encouragement, our healthcare systems, we need to investigate and disseminate, these relationships between healthcare utilization and physical inactivity.
All right. Thank you very much, Dr. Joy and Dr. Ball. For me, I'll take the liberty with the first question here, and I think Dr. Joy has just done a great job at giving us a taste of the amount of work and the amount of years and the evidence that she had to present to get this into the system. And I think for a lot of us, that might feel like a victory. But, you know, Dr. Ball, what I got from your presentation is that's not the end goal. Like, I mean, it's from that point, it's almost as hard getting the data out, cleaning it, and being it into a usable form. What advice could you offer people on this call that might not have that data analyst background, that might not know how to do what you were doing? How can they make use of this data, or what steps should they take that when they do get the physical activity vital sign implemented, they can actually use the data for research and data analysis?
Great question. I'm assuming that, you know, if somebody has an electronic health record, that hospital, that clinic, or that system is going to have data analysts. They have to have data analysts in order to even kind of manage, you know, the software, the front end and the back end of those electronic health systems. So if they have those, there will be some data analysts. It would probably take reaching out to, you know, your IT program or others, and just be sort of looking around for somebody employed with the title data analyst, with kind of the standard title, and they'll be there, and kind of you'll have to navigate your way through to find out, okay, which data analyst, where are they? You know, where is she or he that was working with this data, or that could help me out, and you might have to navigate your way a little around, but there usually is kind of a parent department of data analytics. If there's not, the data analysts may be scattered throughout your system or your hospital, but they should be there if you have an electronic health.
So for a lot of us researchers on this call, it's reaching out to the clinicians and medical directors like Dr. Joy, but at the same time also bridging that gap with the data analytics people, so that when it all comes together, we have usable information.
Yes.
Awesome. Dr. Joy, Mariana and earlier Daniela asked a question about implementation and overcoming barriers. And I don't know if you've read Mariana's comments here, but she's looked at some common themes to overcome. What have you done in terms of work of addressing implementation barriers to overcome these kind of difficulties in getting the physical activity vital sign implemented?
I think the work reading Mariana's question right now actually has happened, you know, post implementation. You know, it is definitely addressed within our care process model, which I have, you know, mentioned several times now in the chat and in my presentation. You know, that is a common tool utilized in Intermountain Healthcare as a way to, you know, inform providers and care team members about a highly impactful topic, and to also talk about clinical best practice and clinical workflow. And so things such as what Mariana is indicating in her comments are addressed within the care process model. And more recently, within the last year, we implemented something called the Intermountain Lifestyle Index, which includes, you know, not only physical activity information, but information on dietary intake, sleep, mental health, and social determinants of health. And so recognizing that there are all sorts of barriers, you know, that influence lifestyle behaviors and physical activity, for example. Now our clinicians can have a snapshot of those lifestyle behaviors and their social determinants. And I tell a story. I'll do this really quickly in the interest of time, but I did have a patient a couple of years ago, and this really, influenced the work I've done more recently around social determinants of health. She is in her 50s. She is obese. She's well educated, has a master's degree. She has diabetes, sleep apnea, well, currently, hypertension, depression, chronic pain. And, you know, every time she came in to see me, I would talk to her about the importance of being more physically active. and how that would, address her depression and her sleep and her chronic pain. And then my nurse walked out of the exam room one day and just kind of was shaking her head, and she handed me the patient's face sheet and told me that, unbeknownst to me, the patient was homeless. She was living out of her car. And so when you think of Maslow's hierarchy of needs, going out and getting 150 minutes a week of moderate to vigorous physical activity just wasn't meeting, wasn't high on her priority list. When she was sleeping in her car, and later told me that, she would try and find a parking lot where she felt safe, where the police or other people wouldn't hassle her. So, understanding, having that holistic view of the patient is really important if we're going to be successful, with physical activity promotion. And then I will add that, giving people advice, to start, increase, maintain, or modify their physical activity is better than nothing, but maybe not a whole lot better than nothing, and counseling takes more time, and there's some challenges and barriers to that, and who's the right person to do it. But we are talking about, what's the best way to do it? Do you use something like BJ Fogg's work with BMAP, with behavior equals motivations and abilities and prompts? Do you use 5As? Do you use the trans-theoretical model? I mean, there's certainly different approaches. I generally share with my physician colleagues, pick the approach you're most comfortable with and use it consistently. You'll get better at it if you're using it regularly. And so, long answer to a short question, but a very complicated and complex question, that there are lots of things that we need to consider, in being successful in promoting physical activity, no matter what domain you're in, but certainly within healthcare.
Thank you, Liz. I believe that question came from Mariana's dissertation work, so we'll be excited to have her present it one time in the future.
Excellent.
Trevor, quick question, Trevor. Have you looked at length of stay in your work, and any timeline on when you're going to have that cost PAVS data published?
Yeah, let me throw a slide up here. We look at, in terms of utilization, we haven't looked specifically at length of stay, but this is just one example of some things we look at. We look at utilization and cost. So we look at stratified by their activity level, whether they're inactive, insufficiently active, or sufficiently active. Just three categories. We look at outpatient visits, average per year, inpatient visits, emergency visits, total hospital charges, that's driven in large part by premiums and other things related. So total hospital cost is a better standard to measure against. But and we do see differences in utilization, and so I would imagine that length of stay, I would guess that there's going to be a relationship there given the relationship of other utilization measures. So, but not yet. And so we have some data like this and some other more robust data where we've actually modeled to predict cost according to how much physical activity patients are reporting to the PAVS getting. And that's exciting work, because we can then look at cost savings, and we can project, okay, if we can get this many patients from 0 to 30 minutes a day or 150 minutes a week, that would be associated with X number of dollars in this particular domain of healthcare costs. So we don't have a timeline right now of publishing this. We are in the process of that work in our system, and hopefully, sometime next year, we'll see that in the literature. And then this slide that's on here is another example of things that we're looking at.
All right, thank you, Trevor. Well, we're right at 11. That's fantastic. We had over 80 people attend. Great presentations from Dr. Joy, Dr. Ball. Thank you both very, very much for this. This session will be recorded. We'll be sending it out to everyone. We plan to have a smaller collaborative mentoring session in December, followed by another large group presentation in January. We'll continue to communicate, but thank you very much to everyone for participating today. And if you have any needs, please reach out to me and we'll do our best to help you out. So thank you, everyone, and have a great day.